Well, hello again, listeners, and welcome to RTMatters. I'm Patrick Dunne, your host, and we got a good one for you today. We're going to talk a little bit more about the impact of artificial intelligence on respiratory therapy practice. This is actually part 2. We did an earlier episode 5, where we talked about just the basic generalities of AI, but now we got someone who can really help us drill down some more. As you know, the integration of artificial intelligence in healthcare is increasing and is creating a whole new era of clinical practice, hospital management, and health policy. Technological is significantly enhancing diagnostic accuracy, operational efficiency, and evidence-based decision-making. And these advancements are not just incremental, they're transformational. It's really transforming the way healthcare is going to be delivered in the future. However, it's important to acknowledge that the path to fully integrating AI in healthcare is not without its challenges. To navigate these complex issues, close collaboration between healthcare professionals and AI experts is essential. That brings me to today's guest, who is a repeat panelist, Dr. Robert Joyner. He previously appeared on RTMatters in episode 6, where he talked about evaluating clinical evidence in respiratory care. And Bob, I got a lot of comments on that particular episode. Since 2019, Dr. Joyner has been the director of the Richard A. Henson Research Institute at Tidal Health Peninsula Regional Health System in Salisbury, Maryland. And that's the major health system serving Eastern Shore of Maryland. Dr. Joyner is a registered respiratory therapist. He also has a specialty credential in adult critical care. He is a fellow of the AARC, and he is also a past president of the National Board for Respiratory Care and one of their former trustees. He's a recognized thought leader, and Bob, welcome to our program today. And I'll tell you the reason we asked you in is because at the end of episode 6, you mentioned that you had some new responsibilities in terms of AI at Tidal Health. And why don't you tell us a little bit about that? And we're really glad to have you join us today.
So first, Patrick, thanks for having me back. Your audience can't see it, but I love your hat, RT hat. Very nice hat. My role in regards to AI at my institution is I'm part of a subcommittee of IT that evaluates AI questions of sort of big questions that are related to how AI is used directly in patient care and decision making, but also questions related to AI in administration. AI in itself is a valuable product in that it can actually do many things beyond just identifying pathology. It can also support things like scheduling. And so there's lots to it.
So essentially, you have a committee at Tidal Health now that'll be evaluating all elements of AI as it being introduced, no matter what the professional responsibility is, like whether it be respiratory, radiology, pathology, nursing service.
Yes, and it's a rather large committee. It includes physicians and nurse practitioners and administration. So there's lots of people associated with that. To be fair, I think the reason that I was invited to join it has to do with my background in research, not necessarily my background in RT. However, I think all of it matters.
It sure does. Well, let's start off with, how do you see artificial intelligence changing the day-to-day practice for respiratory therapists?
Well, again, I want to mention that AI can actually solve many things, or at least support the solution of many things. And I think I want to start with this, just so that you know, I believe that AI gets you about 60% of the way there. I do not believe that AI is a total solution. I believe AI helps you start, especially in places where you might not know where to go with something, but it gets you at a starting point. And the therapist, the thought leader, whoever else that might be involved has to do the rest of it. So how is it going to work out in respiratory care? I believe there's a couple of things that are going to happen. All of us who are a little bit older have spent a number of hours in a back room trying to figure out a schedule for the following month, or maybe 3 months, or however they do schedules. I think AI is going to be highly involved in understanding how to quickly put a schedule together based on particular parameters. I think that AI is going to be very valuable in understanding whether you should pay closer attention to a particular patient based on waveforms from a mechanical ventilator or sort of a generalized analysis of what's going on with a patient. There are AI strategies being used right this second to understand patient demise.
Yeah, well, one of the things you just mentioned was AI being used to analyze ventilator waveforms and to predict a patient's ultimate deterioration or improvement. Do you think they'll ever replace the clinical judgment of the experienced respiratory therapist?
No. And I have, at least not in my lifetime. There's too many factors that go along with what causes patient-ventilator interaction. And it's not just flow pressure in the ventilator, right? It also has to do with what's going on inside the room. It has to do with what's going on inside the patient's thought process, pain, irritation, comfort. All of those things are related. It can make you aware that you should pay attention to your patient. It may be sort of like an advanced sort of alarm, but in itself, is it going to change or completely eliminate the need for a highly qualified respiratory therapist? I absolutely not.
I tell people I don't feel comfortable driving down the freeway and seeing a 18-wheeler beside me with nobody in the cab. So I'm not really into autonomous driving, certainly not into autonomous mechanical ventilation, that's for sure. Well, AI has shown promise, and like you mentioned earlier, in the diagnostic realm of improving interpretation of chest x-rays and CT scans, primarily for conditions like COPD, silent mucus plugs, and pneumonia. How comfortable should clinicians be with trusting these particular tools? And that's probably into the realm of the radiology department.
Yeah, so we've evaluated a number of these tools that could be useful in imaging. And to be fair, I can only really comment on those that we've had experience with. And again, I think it gets you about 60% of the way there. So what the clinician, respiratory therapist, or otherwise needs to be aware of is gaining an appropriate level of skepticism. But I'm not using skepticism in sort of a derogatory way. Mm-hmm. I'm suggesting that use it almost as if it's a colleague. You're not going to instantly believe what someone else is telling you without evidence. However, it is utilizing evidence to come up with what its recommendations are. So I think you should listen to AI. I think you should pay attention to when it's alerting you to something. But I still think the decision-making is going to happen inside of the respiratory therapist, the well-functioning respiratory therapist's mind.
No, I totally agree. I think one of the aspects of AI that people are fearful is that it's going to replace their clinical judgment. And as you're pointing out, it's a complement. AI is a complement to the clinical judgment.
That's a great way to say that.
Now, one of the things that I like that you mentioned earlier, can AI help us move toward more individualized, patient-centric treatment plans instead of one-size-fits-all approach? How do you see AI helping us develop that, especially for the COPD patient who has multiple comorbid conditions?
So an example of this may be something that I've seen with an electronic medical record, and that is AI's ability to summarize the patient's stay over a particular period of time or the patient's medical record over a particular period of time. Being able to take that information, summarize it in a relatively short but intentful format, can be utilized by respiratory therapists to better understand how the patient should be treated for their comorbidities. So what you should think of it, again, I think, is that sort of colleague. It's somebody who's actually helping, but it's not something that's making the decisions for you.
Well, you're making me very comfortable with it because I understand exactly that we have some real advantages to having a computer with machine learning, scan an awful lot of documentation that would take the human much, much, much longer. And at the same time, once the evidence is there, you have to evaluate it. Many RTs say, and I hear this quite often, they're overburdened with documentation, they're understaffed, there's a lot of false alarms. Can AI realistically take on some of that workload to give clinicians more time at the bedside?
So I think maybe, and it goes back to the statement I made about the being able to summarize information for patients, especially those patients that have been in the hospital for extended periods of time. There's lots of things that have happened to them, or been in the hospital repeatedly, or engaged with the ER repeatedly. I think it can help with being better at summarizing or understanding what targets are for a particular patient or even a group of patients. That may be helpful in understanding where that patient should be admitted or how that patient should be treated. And those things can happen in a faster way. So, yeah, I actually do think that potentially it will be supportive in that nature.
Yeah, it provides more information in a much more timely manner that goes into the whole process of care planning.
So just to mention one other thing that goes along with this is that AI now is being explored in remote monitoring. And so understanding how to prevent exacerbations of COPD or treating them earlier so that you prevent readmission or prevent ER visits. That's a place where AI is probably going to become very useful.
Yeah, most of those ER visits for an exacerbation of COPD usually translate to a hospital admission because they usually wait until the last possible moment to get there, and then they're at their worst state. So there's no question early intervention is the way to go.
Nobody wants to come to the hospital. And
that's for sure.
Neither do I.
That's right. Now, this next question has kind of two sides to it. The not so good side is that the teachers in the entry-level programs recognize that they give assignments for papers and the students run to ChatGPT and get the paper written for them. That's not a very good use of that technology. But what about using AI to create scenarios or clinical simulations to help students kind of navigate through some of the cases they may or may not see that often once they get into clinical practice?
So one of the things that you don't have in my background, I don't think, is that I spent 21 years as a faculty member at Salisbury University. So I do have a background in teaching. I can tell you that it depends on what the intent of the education is. If the intent is actually to teach grammar and to teach understanding how to write, then I do believe that things like GPT can inhibit that. However, if the intent is to have someone ask a complex question to support the development of a policy and procedure and teaching students how to do that, I think that actually has some important aspects to it in regards to AI. So I'll give the example that I usually give. Calculators can do trigonometry. Yes, they can, if the person knows how to run it. And I think AI, ChatGPT, Gemini, and all of those different types of AI, I think they're supportive, but you do have to know how to run it. So I think that education systems should spend some time actually teaching students how to do this correctly, as opposed to just worrying that it's going to do their homework. I think we're beyond that. We're beyond use of a calculator. You know, people should use calculators so they don't make mistakes, but they also have to understand what they're doing.
Sure. One of the points you bring up in my mind is the old concept of GIGO, garbage in, garbage out, when we first started using computers. And I think the same thing applies. And I've noticed you can ask different questions different ways. The same question, I should say, different ways with an AI and get different responses. So you're right. You have to be able to frame the question. And that's what I think the critical thinking skills comes into play.
I can tell you that one of the things that I do, and I hope you don't mind me mentioning all of these different...
Not at all. Please.
So there's something called Notebook LM, which is a Google product, and it's what's referred to as a limited language model. You can feed it an article that you're reading from Respiratory Care or Chest or wherever that you're reading it from, and it will actually create a podcast based on that particular article. And I'm using that now to prepare for journal clubs. And so if I'm not presenting in the journal club and I just need to know a background of what the article is about, I feed it and then I listen to it in my car. And I can see all kinds of advantages for students who are learning a particular topic to have an understanding before they come to class. As a teacher or faculty member, we struggle almost on a daily basis to have students come into the class prepared. Mm-hmm. And I think there's different strategies that can be used. One of those strategies could be that they could listen to some material before they come to their class so that they can speak from a more knowledgeable basis. That's good utilization.
Sure, it is. Why don't you mention that source again, that Google product again, for some of our listeners that might be inclined to pursue it?
Yep. It's called Notebook LM. There is a free version of it, just like Chat GPT, there's a free version of it. And I think it's excellent in regards to a teaching tool that's not scary to the professor, right? This is literally trying to get students to come to class prepared. Mm-hmm. I teach that to my residents that I work with here. I teach it in a course that I'm teaching called RIME, which means Research is Medical Education, just to get people more engaged with the literature.
And they come, if they're more engaged, that means there's more collaboration, there's more interaction, and they're not just sitting out there like themselves. And I really think that's part of this whole concept that we're moving toward, which is basically team-based care versus the silo way that it was when we first got into the profession, where you had this department, that department, and this department never talks to that department, and don't you do this, this is my responsibility. Those days are long gone. We just can't afford to have that silo mentality any longer.
Yeah, and I think that's very true for respiratory therapists. I remember 35 years ago, you would treat the respiratory problem and whatever else was wrong with the patient wasn't your problem, right? The evolution of respiratory care as a profession is that we're one of the providers at the bedside, and we care for the entire patient, not one particular aspect of them. And those are the people that are most valuable at the bedside. And I'll keep it with AI. There's lots of learning that can be done with AI and support that can be provided that was never there before.
Mm-hmm. One of the points that you bring up that I have seen, especially in some of the articles I have read about mobilizing patients on mechanical ventilation, that's really a team effort. You have the respiratory therapist taking care of the ventilator problem. You have the physical therapist helping with mobility and ambulation. You have the nurse making sure that everybody is working together and documenting. And there was a study just out that they actually have a member of the patient's family as part of that team, which basically allows everybody to contribute to that patient's well-being and get them off that ventilator a lot faster.
And that's sort of dealing with all of both the physiologic problems with mobilizing someone, but just listening to you, it also is handling sort of some of the psychological issues that are going on in somebody who's been on a mechanical ventilator for an extended period of time. That is holistic patient care, and we're involved.
That's right. Now, there's always this question of trust, as we mentioned earlier, about the AI model making a recommendation and the RT judgment. I'm not really too sure about that. Who basically has the dominant play here? I think I already know the answer to this, but I just want to have you say it.
Well, the respiratory therapist has the dominant play, but what you have to be careful of is taking in what the AI is telling you. You take it in and you critically think about it. Because while there are times when AI hallucinates or provides you bad answers, those sort of things, that's true. It's there. For the most part, it's providing some good feedback. And if you're going to do something against what it's telling you, if that's what you're going to do, then just be aware of why you're doing that. If what you say is, I don't think, right? And I think I said this in the last podcast that we did. I don't think very well. Like, have data to support your own side. If you don't agree with what your input is, then provide it some more input. Make sure that you're making good decisions. but the decisions are yours. Nobody's going to yell at the AI machine.
That's right.
Nobody's going to blame the AI machine. It's still you making the decision.
That's right. You really dream home a very important component that I'm sure you've been dealing with your entire career, and that is, are we teaching critical thinking skills to the level where we should? And it seems to me that we now need those critical thinking skills much more so than ever before if you're going to be successful with AI as a partner.
Yeah. It's interesting as a teacher, and I know that you have teachers that listen to this podcast, and I feel for them because I've been in this discussion so many times where somebody will say, well, you need to teach them critical thinking skills. And I get it. I completely get it. And I want to immediately say, if you know how to do it, tell me, because I'll. It's very difficult. I think education. This goes a little bit away from AI, but I think education is a bit like exercise and training. It's painful for students in the beginning, right? And that is something that they want to veer away from. That's the process of building critical thinking skills. But I promise you, and if there's students that are on here, that will come to a place where you'll enjoy the learning. But you do have to get there first. I'm going to keep bringing this back to AI, and AI is a useful adjunct for you. It doesn't do the work for you. You should never view it that way. But it is something that can support that development of becoming a good critical thinker.
Yeah, I think one of the points that I fear, and you probably share with me, is people look at AI as an easy way out. In other words, I don't have to worry about it. AI will take care of it. And that's exactly the opposite of what you're saying. And what we're thinking about is that it's basically going to help you look at things a little differently, but it's not an easy cop-out for you to not do anything.
I am very concerned that people will just believe AI and it will take you down the wrong path. That's not me. I'm only suggesting that AI has its limitations. One of the things you can think of is it is creating information. It's summarizing information from the information that it receives. And if you believe that some of the published data is questionable, if you already believe that, which I think many of us want to be able to assess information well, we believe some of it's questionable and some of it's very good. AI is taking it all in, including the stuff that maybe you wouldn't allow in if you were reading it directly.
In our previous podcast, you mentioned about predatory journals, where they actually will now be publishing under the guise of peer review. Why don't you reiterate how that is going to have a negative impact on AI?
Well, I will tell you that for $5,000, there are journals out there that will publish virtually anything. And yes, I do think that there are people that can write a question in the AI and submit it. And there will be journals for a cost that will actually publish it. That's not good. Those sort of things, peer review is the best that we have. Many people question it. Many people question its value, but it also is a little bit like critical thinking. It is currently what we have, which is the best way to assure that you're publishing something that's good research. If there are other ways to do that, I welcome you in the discussion. I would love to have those discussions with people.
Yeah, see, once it's in the public domain, no matter what the source, is eligible for AI review. And it might just get bashed in there. So that's a real point. We'll talk about the guardrails here in a moment about how all people using AI have to be careful. And now, let's just put your futuristic hat on for a second. If you could imagine an ideal AI tool for respiratory care, what would it do and how would it transform the profession?
So, to be fair, I spent a lot of my time in critical care. And so most of my viewpoint comes from critical care. I spent a lot of time in the nursery. I spent a lot of time in the PICU. And I spent my fair time with adults, but all virtually critical care. The complexities of critical care and the amount of data that's being published today compared to when I first started, it is unreasonable to believe that someone can keep up with all of that information without some sort of adjunct. I believe AI is going to play a role in that, in supporting finding the best data for the circumstances that you provide it. I think that's true for mechanical ventilation. I think it's true for the pharmacology that we use and the changes in the way in which the pharmacology is used. And I think it's true in regards to those particular patient diseases that we work with and what are the best ways to do that. I think AI has a role in that. I don't think respiratory therapists should just push it away because they believe that somehow it's going to take their job. I don't think that's true. I think the job is becoming more complex, and to be the best practitioner that you can be, you have to be the most well-informed, and AI plays a role in that information feed.
Sure does. One of the points that comes up, at least in my thinking, and I've seen several editorials, and that is with AI, are we going to lose this personal touch? And our former, now emeritus director of the ARC, Sam Giordano, years ago would say, what respiratory therapists bring is a human touch when you talk to your patients and you work with your patients. And I don't see AI ever replacing that, but I can see some therapists saying, well, that's not my job anymore. But that personal touch is what really gets the message home to get the patients to do what they're supposed to do for the right reason.
You know, every respiratory therapist has patients that they remember, right? We all talk about them back in a war room or however you want to say that. And I can tell you that one of the examples of that I have is a relatively young gentleman who had been in a car accident, and I was about to intubate him. And he was awake and alert and confused by all of the stuff that was going on around him. And he looked up at me and he said, and he's a young, virile guy, right? This is a young, virile person. And he said, I'm afraid. And the discussion between him and I that happened in the next 3 minutes can't be replaced by AI. There's just holding a hand, telling a parent their kid's going to be okay, telling someone, just wait a minute, give me a chance to work with this. None of that can be taken away. And that is where respiratory therapists shine. Because quite honestly, we work with people who are afraid. Because if you're ever really short of breath, right, that's a terrifying experience, not only for you, but for the family members that get to see that for the first time. And we play a role in making sure that people feel confident that the best is being done for their family member. And for the patient themselves. Yeah,
that humanism in AI, it sounds like an editorial coming out of somebody's mind here pretty much, because you're right. It's on its tendency, it could depersonalize because you're looking at a computer screen. But at the same time, the caregiver is the individual back and forth. And that humanistic interaction is very important. Finally, that's
worried is, just so you know, I'm more worried about the effect of sort of healthcare becoming strictly a business practice than I am worried about how AI will affect healthcare.
Right. Yeah, that's really a problem with all of the pressures on healthcare today and all the unknowns with the impact on the Medicaid cutbacks. And it's just really a very, very tenuous time. So it's not just AI, it's the whole healthcare delivery system in this country. Now, let's talk about the guardrails to ensure that the introduction of AI is done properly and with recommended protections. That's what your committee is for. And some of the things you will look for, one of the points that come up is the black box. That is the algorithm that might be behind this ventilator waveform interpretation is not transparent because it's proprietary. But we need to know what's in that black box if we're going to be able to evaluate whether or not that has the evidence behind it.
So in my experience with this committee, what you know, no one's probably going to tell you, the company's probably not going to tell you exactly what's being done, right? However, you do have a right to understand how the algorithm was developed, meaning that if you're using AI was trained in some way. Having some understanding of what that training involves. Did it involve 3 patients, and that now you have an algorithm? Did it involve 100,000 records, and now you have an algorithm developed? Did it only include a particular subset of patients or a small population? You need to know all of these things, and you need to have some good grasp on things like sensitivity and specificity. So the understanding of how often it's going to identify something as being there when it's not, or how often it's going to identify that it's not there when it is, right? So false positives and false negatives. You have to have some understanding of the limitations, because AI is always limited. To be fair, every practitioner is limited too. The question just is, can you make them both better when you use them together? So I implore your audience to, when they're investigating whether they're going to take in an AI product, and I think they're coming, then understand a little bit about how it was trained and developed so that you can understand the limitations that it has.
And that's the transparency, but there's also, as you pointed out, some bias that goes into that algorithm formulation by the developers. And bias mitigation is we talked about that in our previous podcast about how you evaluate evidence and how do you get rid of bias in the peer review process. So bias is something that really is not going to go away.
No, bias won't go away. You try and mitigate it or limit it. And that has to do with how was the model developed. So what was used to train the model? And that should be something that the company who developed the product is willing to provide you information about. If they're not, then that's kind of the end of the conversation.
That's an important guardrail, bias mitigation, right up there with transparency. How about privacy and security? That seems to be obviously because of HIPAA and also because of ransomware. Those are real serious issues. How do we address privacy and security of data?
So they are serious issues. Feeding AI virtually anything, right? If you're not, again, it goes back to how is the model developed. You do have to have some concern with its ability to identify individual patients. I think that there are rules in place that are supposed to be preventing this. Whether those rules that are in place will be effective at 100% effective at preventing identification of individuals or their information. You know, the reality is I no longer believe in 0 and I don't believe in 100%. I don't think anything's perfect. And I don't think there's a product that never works. The only advice that I have in regards to that is to stay aware.
Yeah. So some of the people in your committee probably represent the IT department and electronic medical records for that exact purpose, to make sure that security is maintained. How about this?
And to be fair, in the electronic medical record, there are AI products that want to be able to evaluate the information in the electronic medical record. I mean, it's directly delving into that information.
Yeah, it's very important. The other thing is that just bears to what you talked about in the past in terms of your research hat, and that is you have evidence being presented. How do you validate the veracity of that clinical evidence? And that's something that I know that you very dear and close to you, and because of your career change, especially at the Institute.
Don't ever believe that one paper tells you the whole story. One of the advantages of AI is especially in these limited language models where you can put things into them. That idea that you can put all of this information together is very helpful. I do know that when you search Google's actually designed to give you a positive search. So you have to realize there's bias in that. If you're searching for something, Google will feed you what you're searching for. That in medicine is not necessarily a good idea. You have to systematize the way in which you're doing your searches and systematize the way in which the AI is actually being fed the information that it's trained with.
One of the hallmarks of good clinical research is that the patients, the subjects that come into the study are fully informed of the risks, of the potential outcomes, potential for harm. I believe informed consent has a role in AI, as you obviously feel as well. How do we make sure that that is actually accomplished and patients are fully informed that AI is being used?
You're asking a very good question that I have two answers for. When you're involved in a clinical trial like the ones that we perform in the Research Institute here, the informed consent process is extensive. When you're a patient that comes into the ER and you sign all of those forms off that you sign off, there probably is AI information in there that suggests that your information will be used in AI. Whether that second piece is actually informed consent or not, it's called informed consent. But when you work in a research area like I do, the informed consent process is very different. And as a matter of fact, if you work in a clinical trial like we're doing, the informed consent that you get to come into the hospital is insufficient. You actually have to have an informed consent for the clinical trial itself.
So that's another issue in terms of the guardrail that the institution has to look at, which I'm sure your committee is also dealing with right now. How often does that committee meet, Bob?
We meet once a month. Yeah. To be truthful, we probably don't need to meet more frequently than that. The digesting the information that we get for each meeting actually takes a little while. Because it's all about how did the model get developed, what information was fed to it. Again, sort of some statistics, sensitivity, specificity. And then you also have to know that there are various forms of AI. They could be administrative and functioning to help the financial department. They could be administrative related to things like scheduling, or improving that side of it, but they can also be clinical. And so it depends on what particular avenue that you're looking at in any particular month.
Yeah, but it seems to me that best of all is to have everybody at the table, even though administration might not be clinically oriented. What they do with the data and with the transcription of the data is very important. As
I think one of the funnest committees that I'm on, because the conversations are academic and lively.
I can imagine.
Very
have you implemented imaging support in AI for your imaging departments? Because that seems to be where the first breach is going to be in terms of using AI to get a better handle on imaging.
So it's interesting. We have looked at a couple of different imaging softwares, and then our most recent discussion will be about imaging, but it's not about analyzing an image. It's about the instance of finding information in physician notes and whether or not the patient who had a incidental finding actually followed up with that incidental finding. So you can envision that, by the time you reach the age of 60, somebody takes a chest x-ray or a CAT scan for some reason, the number of incidental findings go up. So what do you do about it? The answer is in 6 months, you're supposed to have it checked in and checked again. So the question becomes, are those patients actually being followed up the way in which they're supposed to be? And AI is being used to help understand that follow-up.
Well, you've certainly given us an awful lot of good, deep information based upon personal experience, and it really validates the fact that you are indeed a thought leader. Based upon input we get, we'll probably come back and talk with you some more, if you'd be willing to do that at some point in time.
I would love that. It's a joy to be here and a joy to talk to you.
Well, listeners, that brings us to the end of this episode with Dr. Robert Joyner having another dive into AI. Remember, we do want to hear from you about what we can do better, what we're doing okay right now, and as feedback at RTMatters.com that comes directly to me. Any further information about anything mentioned in this podcast, I'll be happy to share with you as well at that website. So until next time, go out there and, as Bob said, be the best respiratory therapist you can be, because that's how we hope you were trained. That's what our patients expect, and we expect nothing less of you as well. So take care, be safe, and we'll see you next time.
Thank you.